first of all, what we'll do is, can you identify what this is? This is not a human anatomical anything. What is it? It's a golf ball on a tee, right? So the shoulder is like a golf ball on a tee. This is the humeral head and this is the glenoid. So it's a very small glenoid on which the humerus is there, okay? So it needs a lot of stability to hold the humeral head inside the glenoid cavity. So imagine this is the glenoid and this is the humeral head, okay? So it's a very unstable joint. There is not much of a stability here because if you compare it with a hip joint, the hip joint is, something like this. So this is the hip joint. So this has the acetabulum which has it covering so much of an area, right? So it's a much more stable joint than the shoulder joint. This is the glenoid, this is the humeral head, okay? So that's why it's very much more prone to injuries. So now we'll come to injuries around the shoulder, okay? So first we come to the anatomy. It's very simple anatomy. The scapula is there. The proximal humerus, one second. So this is the scapula, this is the clavicle, this is the sternum, this is the opposite side clavicle, okay? The humeral head. So you don't need to, with the incidence, we don't need anything. So what injuries can occur here? Three things can be injured. One is the clavicle, okay? So the clavicle may be injured, the scapula may be injured, and finally the proximal humerus may be injured or the shoulder joint may be injured where we have shoulder dislocations, okay? Also the nerves and vessels are very close by. We'll see in the next slide. So in an injury around the shoulder, there is a very high chance of neurovascular injury. So this is another picture which is much more visible. So the glenoid is very small, so it is very easily dislocatable, the humeral head. And this is the labrum that is covering the glenoid, giving it additional stability. If this was not there, this would have been kept on dislocating for a long time. So that's why we've been given a glenoid labrum to keep the shoulder joint stable. And these are the ligaments around the shoulder, keeping it stable, okay? If these were not there, this whole thing would have collapsed. These are the muscles, we'll come to it later, because whenever there's a fracture around the shoulder, the muscles cause the displacement of the fracture in various locations. So first, as I said, clavicle fracture, okay? So this is an X-ray of a clavicle fracture, as you can see. This is the fractured clavicle. This is one fragment and this is the other fragment. Very common injury. You will be given X-rays in the final exam of clavicle fracture. Very common injury. It is caused due to fall on outstretched hand. One person is falling on an outstretched hand. The whole pressure is going through the clavicle and it fractures. So it is the connection between the axial and the appendicular skeleton, okay? That's why it's a very prone to injury, okay? So this is how the fragments are displaced during a clavicle fracture. Due to the muscle pull, this fragment is pulled upwards, this fragment is pulled downwards. That's why we have displacement always in a mid-shaft clavicle fracture. So what are the clinical features? Also there is another cause of a clavicle fracture. In the anatomy, have you studied? There is a change in the anatomy in the middle 1/3. What happens? From cylindrical, it becomes flat, right? This part is cylindrical and the lateral part is flat. So that causes, that place is very prone to injury. So that place is the most common place of the fracture, middle 1/3. So what are the clinical features that will be there? Pain, swelling, tenderness. The skin may be tented, there may be, the fragments may be impinging on the skin. Open injury is very less. Vascular complications are there. If it's in the left side, what is passing underneath? There is a very big vessel passing underneath. Yes, the subclavian vessels. So this may be injured during the fracture. So this is again what I was saying, cylindrical to flat. So the middle 1/3 is the most prone to. This is the cross section, cylindrical, and it keeps on getting flatter as we go laterally. So this is the most prone part for fracture. So they are classified according to location, very simple. Mid shaft fractures are the maximum. See, 76% are mid shaft because of the same thing. Lateral end fractures are also common, 21%. Medial fractures very rare, 3%. Very rare medial fractures are not that much seen. So this is a middle third fracture. This is a lateral end fracture. What happens in a lateral end fracture is there are ligaments here. These are the AC ligaments, acromioclavicular ligaments. Okay, this is the clavicle. This is the coracoid. So this is CC ligament. CC means coracoclavicular ligament, and this is the AC ligament. Acromion. This is the acromion process of the scapula, and this is the coracoid process. So AC ligament. So these ligaments are injured most commonly in a lateral end fracture. Okay, so this is what you need to know. Whenever this X-ray is there, they're going to ask you what will be the management. So your answer, yesterday I was also teaching them, every time you're going to be asked what is the management of the patient if the patient has come to you with this sort of an X-ray, this sort of an X-ray in the emergency. Patient is saying that I had a fall, after that I had pain, tenderness, swelling of the area, inability to move the arm, and the patient has already done the X-ray and come to you in the emergency with this X-ray. So what are you going to do first? You need to stabilize the patient first, okay? There may be other injuries also, there may be head injury, there may be other injuries, so you need to exclude all of that. So what the examiner wants to know is whether you know the initial management of the patient or not. So obviously the first answer is going to be ABC, airway, breathing, circulation. I'm going to check, stabilize the patient first. Then the examiner will ask you what is the management of the patient that you will do in the emergency. So what will you do? Two things. One is, this is a figure of 8 bandage. This is a figure of 8 bandage, also known as a clavicular brace, okay? And you keep the patient in an arm pouch or an arm sling, okay? So arm sling as well as this. This is how you immobilize. Then further management we'll discuss later. But this is what you are going to do in the emergency. Figure of 8 bandage and arm sling or arm pouch. This is also commercially available as a clavicular brace, but what you need to say is figure of 8 bandage. So now it may be managed conservatively. If there is less displacement, you can manage it conservatively, keep it in a figure of 8 bandage as well as an arm sling, and it unites in 3 to 4 weeks. However, if there is much more displacement, okay, so what are the indications of operative management? One is open fractures. There, as I was saying, there may be tenting of the skin, there may be open fracture. There may be neurovascular compromise. If the vessels and nerves have been damaged, then definitely you need to fix it, because you need to also see the, open it and see the vascular and the neurological status inside. Also floating shoulder. What is floating shoulder? So when the clavicle and the scapula have both fractured. So what happens is, one sec. If the clavicle has fractured and there is also a scapular fracture, this is known as a floating shoulder, because this part is becoming mobile. This is floating. There is no support here. So you definitely need to fix either one or both. Clavicle along with scapular fracture is known as a floating shoulder. And if there is non-union, if you've tried conservative management and it is not uniting, you're seeing in 3-4 weeks there is no union there, then you need to go in for an operative management. Operative management, all these you don't need to know. What you need to say in the examination is ORIF. What is ORIF? Open reduction and internal fixation. So what does that mean? Open reduction is you're giving an incision over the bone, you're opening it. You're seeing the fracture, you're reducing it, that is open reduction. Internal fixation is when you're fixing a plate or nail, it may be a nail or a plate, but you're fixing something inside the bone or over the bone, that is internal fixation. So everything operative management in orthopedics mostly is ORIF, okay? Open reduction, internal fixation. So these are plates and screws that are used for stabilization. This is that X-ray fixed. That clavicular fracture X-ray. This has been fixed with a plate. Okay. So what are the complications? As we were saying, vascular injury, nerve injury, lung injury may be there. This is a very another complication. Lung injury may be there. You always need to see the chest X-ray of the patient because there may be associated rib fracture also. Late malunion, non-union, these are complications of all fractures. So this is a common answer for all. What are the complications? First is non-union, malunion, but in this early is neurovascular injury in clavicular fracture. Okay. Now, next part, we've done the clavicle. Now we're coming down to the proximal humerus. So proximal humerus has these two necks. Okay. This is the anatomical neck and this is the surgical neck. And this is a 4-part fracture. Why 4-part? 1, 2, 3 and 4. Okay. This is a 4-part fracture of the proximal humerus. Because it is a cancellous area. There is cancellous bone there. So that's why the fracture is always displaced and always has comminution. Means there are many different fragments. Whenever there is a fracture of the proximal humerus, there are fragments like this. Sorry. So now, as I was saying, the muscles cause the pull of the fragments away from the bone. So if there is a fracture here, so the subscapularis is pulling this part away, the supraspinatus is pulling this part upwards, and your biceps is here. This is the biceps. So because of the pull of the muscles, so there is displacement of the fragments, and that is always the case in a case of proximal humerus fracture. There is displacement of fragments. This is an isolated greater tuberosity. This is a greater tuberosity. One sec, I'll go back. This is the greater tuberosity of the humerus, and this is the supraspinatus is attached here. Is attached here, and see now, that part has fractured, and it has gone upwards. So it has been displaced by the muscle. So in proximal humerus, what you need to know from an examination perspective is what is the classification. It is known as needs classification. This is important, that's why it's given in red. Needs classification, and we need adequate radiographs, adequate CT scan to because of the displacement of fragments, we need to know where the fragments are. So we need a CT scan to get to know the fragments. These are the X-ray views. You don't need to know. Achha, this is the needs classification. Okay, this is 2-part fracture, anatomical neck. Okay, the anatomical neck has been fractured here. Surgical neck fracture is below here. It may be of 3 types. This is again, but this is 2-part. Okay, greater tuberosity, only the greater tuberosity has been fractured. We saw a little earlier. 2-part. It may be 3-part also. The greater tuberosity is separate, and there is also anatomical neck fracture. It may be 4-part also, with a lesser tuberosity fracture as well. So this has become 2-part, 3-part, 4-part. Lesser tuberosity fracture may be there isolated, very rare. This 2-part, this is 3-part because the humeral head is separate, and again this becomes 4-part. And there may be fracture dislocation also. This you don't need to know that much because we will come to dislocation later. So there may be fracture along with dislocation of the humeral head. So here we see the humeral head is inside. So this may also be the case. Okay. So now 1-part fracture. So there is no fracture displaced more than 1 centimeter or 45 degree. This is what a 1-part fracture is. The management is usually immobilization if there is not much displacement. If there is displacement, you need to fix it. 2-part fractures displaced more than 1 centimeter or 45 degrees. The fracture may be extra-articular. If it's extra-articular, then AVN is not that common. If it's intra-articular, however, AVN may be a complication. So you may go ahead and fix it. So close reduction can be attempted if there is a 2-part fracture. In 3-part, it is always operative. 4-part, always operative. And if there is displacement or dislocation, you are always going to go in and ORIF. Okay. So close reduction can be attempted. Test for stability if unstable, then percutaneous spins. Again, that's an operation. So percutaneous spins could be there. Achha, what is CRIF? Do you know? You know ORIF, open reduction internal fixation. What is CRIF? What is C? C has changed. Closed reduction. So in that case, what is happening? We are not opening or giving an incision and opening the fracture. We are reducing it closed by traction or other means, and then we are fixing it from outside. Okay. So this is a CRIF, closed reduction and use of percutaneous pins. We've not opened the fracture. This is a C-arm picture, intraoperative picture. This is, we've reduced it with traction and we've inserted. These are K wires, okay? These are K wires that have been inserted to fix the fracture. So this is CRIF, not ORIF. This is the how you insert the pins. Not need to know, I'm just showing you because the K wires are used, 2 K wires from here and 1 K wire from here. This is ORIF because there is plate and screw inside, okay? So it has been opened, the fracture has been opened and then reduced and then plate has been given. Now 3-part fractures displaced more than 1 centimeter or 45 degrees, always I told you it's ORIF. You put a plate, go inside and put a plate, and you have to also suture the muscles there. 4-part fractures. If 4-part fractures, there's also another caveat. In 4-part fractures in elderly patients, very osteoporotic bone, they have lots of comorbidities. So you don't want to anesthetize the patient and go in for a surgical thing. If there is not much displacement, you can leave it as it is. It's called bag of bones and it unites well. So there is optimum range of motion. However, if the patient is younger and patient has wants the movement to return, then obviously it's ORIF you need to manage. So in young patients, proceed with ORIF. There's also another management for 4-part fractures or 3-part fractures, which is known as shoulder joint replacement. Okay, this is a shoulder joint replaced. We've replaced the humeral head with a prosthesis. This was the fracture, it was not manageable. So what we've done is we've taken out the fragments and we've put in a prosthesis. Like hip replacement, this is shoulder replacement. Okay. So what are the complications of proximal humerus fracture? Again, same thing. Neurovascular injury may be there. Stiffness of shoulder is a late complication. If you are managing conservatively, you're keeping it immobilized for a long time, then there is a chance of stiffness of shoulder. But however, it improves with physiotherapy. Malunion will be there. Avascular necrosis of head of humerus is a very important complication if there is anatomical head fractures, because the blood supply is cut off, okay, to the head of the humerus. So it may slowly, you are seeing in progressive x-rays that there is shrinking of the head. Now, the most important thing for your examination is shoulder dislocation. This has, you're going to get short notes, you're going to get practical. In the practical, you're going to be asked this, you're going to get x-rays for this, okay. So, what is shoulder dislocation? It is the dislocation of the humeral head from the glenoid cavity, okay. It's a very common injury, especially in sports persons, it's very common. So, how do you classify it? You classify it according to position, okay, position of the humeral head. So, it may be anterior. Anterior means the humeral head is anterior to the glenoid. Posterior, where the humeral head is posterior to the glenoid. And inferior, means it's below the glenoid. So, in anterior also there are four types. Subcoracoid, whether it is under the coracoid process of the scapula, that is the most common. Subglenoid means just below the glenoid. Subclavicular, under the clavicle, and intrathoracic. It's very rare. Intrathoracic is very rare when it's inside the thorax. So, how does this occur? There is a forceful abduction or external rotation. So, there is abduction, external rotation. This is how it gets injured. Okay. So, in sports players, they're playing a backhand, they're playing this is the forehand. If you're playing like this and it is sufficiently externally rotated, then it gets dislocated. Okay. Also, there may be a direct blow and forced elevation and external rotation. Always external rotation has to be there for the humeral head to dislocate. So, this is a normal shoulder. As you can see, the glenoid and the humeral head. This is a dislocated shoulder. This is an anterior dislocation. Now see, the glenoid is here, but this has dislocated anteriorly subcoracoid. It's underneath the, this is the coracoid process and subcoracoid. Anterior dislocation, okay? So when there is dislocation, there is always an injury to the labrum, which we were discussing about. There is a coating over the glenoid to increase the stability of the shoulder joint. This glenoid labrum is injured because otherwise the dislocation will not occur. So this glenoid labrum is injured when there is dislocation. This is a normal shoulder, this is a dislocated shoulder. See, this is a normal shoulder and this is anterior dislocation. It's very important to diagnose. First of all, what you're going to see is the relation with the glenoid and the humeral head. This is the normal. If the glenoid is empty, that means there is dislocation. You always have to see the glenoid. The glenoid is empty means there is dislocation of the shoulder. So, what are the symptoms? Very simple. Shoulder pain, they will be there. Restricted movement of the joint. And there will be abnormal alignment of the shoulder. There will be deformity. This normal contour of the shoulder will disappear. There will be empty. This place will be empty if there is a dislocation. Okay. Normal contour of the shoulder will be distorted. Nerve injury may be there. If the dislocated shoulder has gone sufficiently below, then nerve injury may be there. Muscle weakness around the shoulder, rarely. So the arm is in slight abduction and external rotation. That means it's like this. The patient will be holding the hand like this. Okay. Internal rotation and adduction are limited. You will not be able to do any clinical tests because the patient will be in severe pain. It's an emergency. You need to reduce the humeral head into the glenoid as soon as possible. The humeral head can be palpated in front of the shoulder. Movement is very painful. Axillary nerve may be injured because the axillary nerve is right below. So during dislocation, the axillary nerve may be injured. So there will be paresthesia over this part of the shoulder. Now we come to posterior dislocation. Posterior dislocation is when the humerus head is adducted and internally rotated. It's like this, and you are getting an injury, so this goes posteriorly. It's a rare injury. It is usually, this is the important part, usually due to electrocution or seizures. If there is a clinical scenario that you are being given, even in MCQs, there will be, this point will be there. Following electrocution or seizure, the patient is having restriction of motion, and then there will be an X-ray or there will be a clinical scenario. This is the important point, electrocution or seizures. These cause posterior dislocations in most of the cases. Okay. So arm is internally rotated, adducted, and external rotation is that was abducted and externally rotated, the anterior dislocation. But this one is internally rotated and adducted. These are often missed and misdiagnosed as a frozen shoulder. So whenever, if you are having a doubt, always go in for further investigations, go in for a CT scan, go in for a MRI to diagnose if you are having doubt in your mind regarding the X-ray. So treatment is non-surgical treatment, conservative. How do you reduce a shoulder? There is a mnemonic, okay? This is the mnemonic, TI, T-E-A-I. So what is the full form of this mnemonic? This is how you reduce a shoulder. T is for traction, yes, traction. E is for external rotation. A, what is A? Adduction. How can you do adduction when you are externally rotating? It's abduction. ABD, abduction, okay? And I is? What is I? Why have I given a hyphen here? So there is external rotation, how will there be internal rotation? Internal rotation is the last thing that you need to do. After this has been reduced, then you do internal rotation. That's why there is a gap here. अच्छा एक्जन आई हम देखिए दी this is external rotation and this it is already abducted, so this is abduction to koda here. This is how you reduce the shoulder and you apply pressure here, so this gets reduced. After that you do internal rotation and this is how you place it. This is TI. So that is what is TI. So traction, external rotation, abduction followed by internal rotation. That's why there's a gap here. TI. This is how you reduce a shoulder in the emergency, okay? Now, if you are not able to reduce it, there are many cases where you will not be able to reduce it because there will be severe muscle spasm. So then you need to definitely go into an OT and then anesthetize the patient and then try this same maneuver. So manipulation under anesthesia is indicated in patients with severe muscle spasm, severe uncooperative patients, or in elderly patients where you are where there is osteoporotic bone and there may be fracture if you are manipulating too much. So there are many methods. The Hippocratic method is longitudinal traction and counter force to the axilla. Very crude method. You have to give extreme amount of traction. Cocker method. This is what I have taught you, the Cocker method. TI is the Cocker method. Okay, so Hippocratic method is you are applying traction just to reduce it. This was done in earlier days. Now we are doing this, the Cocker method, that is TI. Stimson method, patient is prone and arm is allowed to hang over the edge of like this. It's the patient arm is hanging and a weight is given over the hand to relocate it. Milch method, just know the names of this. If you are having a short note, you have to write the names. Hippocratic method, the Cocker method, that you can write this down. The Stimson method, where there is a weight given and the patient is prone. The Milch method, successful atraumatic, abduct the patient's arm with one hand while applying pressure to the humeral head with the other hand. This is also a modification of this procedure only, because unless you do all these things, the shoulder will never get reduced. Anterior shoulder dislocation. These all methods are methods of reducing an anterior shoulder dislocation. This is what we do in the ER. That this you also will be doing in a few months' time, I guess. So this is a gown of the patient that has been kept under the shoulder. This is the counter traction. So can you understand the amount of traction that we are giving? This much of traction needs to be given to reduce the shoulder. So after you've reduced the shoulder, what do? You immobilize the shoulder with an arm pouch or an shoulder immobilizer. Shoulder immobilizer, you immobilize the shoulder and for a period of 3 to 6 weeks. Usually 3 weeks. After that we start gradual physiotherapy, and there is something physical therapy that focuses on strengthening the muscles. Overhead motion should be avoided. Overhead motion should be avoided because it leads to redislocation. So overhead movement should be avoided. So what are the complications that may occur? Rotator cuff tear may occur because the muscles may be torn while the shoulder is dislocating. There may be nerve injury, axillary nerve injury, vascular injury, very rare. Fracture dislocation, there may be fracture, as you were seeing, there may be fracture of the proximal humerus along with dislocation. Shoulder stiffness is a late complication. Unreduced dislocation is a very important thing. If you have a doubt, then please get further investigations done to diagnose. And recurrent dislocation. Recurrent dislocation is in a patient who has the shoulder is unstable, the labrum is torn, and after reduction of the shoulder, after 3 weeks, patient is doing physiotherapy, again the dislocation occurs. And again you are reducing it, again it is occurring. So this is what is recurrent dislocation. So recurrent dislocation, if it is there in the patient. So there may be two things that are there. One is the Bankart lesion and the other is the Hill-Sachs lesion. How do you remember what is Bankart and what is Hill-Sachs? Bankart lesion occurs in the glenoid. Hill-Sachs occurs in the humerus. This is the Hill-Sachs lesion. It is occurring because there is this glenoid is impinging against the humeral head. So always remember H for H, okay? Hill sac for humerus and Bankart is for the glenoid. Bankart is this lesion. The glenoid is getting injured by the humeral head and Hill sac is the humeral head is getting injured by the glenoid. So H for H is Hill sac is always in the humerus. These are features of recurrent dislocation. Because of injury, the shoulder is prone to more dislocation. So this is the Hill sac lesion and this is the Bankart lesion in the glenoid. Okay. Now we've completed that. Next we come to humeral shaft fracture. So what clavicle we did proximal humerus fractures. We've done shoulder dislocations and now we are coming to humeral shaft fracture. So humeral shaft fracture, very simple to diagnose. There will be deformity. 2 full-length views of the entire arm is required. They often present with neurovascular injury. So whenever there is a shaft of humerus fracture, there is always displacement of the fragments due to the muscle pull. So this is the muscle pull, that's why there is displacement of the fragment. The proximal fragment is pulled upwards and the distal fragment remains where it is. So it is classified according to the pattern. Transverse, there may be this is transverse, this is spiral, this is oblique, okay, and comminuted, means 3 fragments are there. These are the types. Management is if there is not much displacement, we can try conservative management, 98% rate of union. This, what you need to know is the names, hanging cast, U-cast, humeral brace. So what is a U-cast? I'll just show it to you. This is the shoulder. The plaster goes from here, comes here, takes a U and goes here. This is the U. This coming here and going here, U. So you keep it in a U-cast, okay? U-cast or a hanging cast or a humeral brace. This is the conservative management of humeral shaft fractures. And operative management is when there is too much displacement. There is loss of reduction after you have conservatively manage the patient, but you are seeing that there is no reduction. Open fractures, vascular injury or neurological injury, definitely you have to go for ORIF. Segmental fractures need ORIF. Floating elbow, again, this is humerus shaft plus clavicle fracture, is also known as a floating shoulder. Humerus clavicle shaft plus scapula, as well as clavicle shaft plus humeral shaft. So this is a displaced fracture and this is the internal fixation that has been done for the fracture. This is a plate that we've applied. This is a dynamic compression plate, okay, that we applied here. You can also use nails. So what is the difference between a plate and a nail? This is a very common thing. What is the difference between a plate and a nail? Yes, the nail is intramedullary and this is extramedullary because it's on top of the bone, okay, and this is intramedullary fixation. So this is a nail that has been done and it has united. So what are the complications that may be there? Radial nerve injury is there. It's very important. It is when there is a radial nerve injury, this is an MCQ. It's known as the Holstein-Lewis fracture. Okay. Radial nerve injury in 18% cases, when there is radial nerve injury along with shaft humerus fracture, it is known as a Holstein-Lewis fracture. Neuropraxia may be there or axonotmesis. Whenever there is you are getting a neurological symptoms in a patient of a humerus shaft fracture, you need to definitely go in and explore the nerve when you are fixing it. So this is how the radial nerve goes. You've learnt in your anatomy. So this is how it is injured. If there is a distal third fracture of the shaft, it injures the radial nerve here. So whenever you're going in to fix the fracture, you have to see the radial nerve and its continuity. Non-union is very common. Non-union class hoye to there. What are the types of non-union? What is this non-union? This is hypertrophic non-union. This is atrophic non-union. Why there is hypertrophic? Because there is callus, but there is no union. So we thought we'll complete this class as well. So forearm fractures. What is the forearm? It's from here to here till the distal radius. Okay. So forearm fractures frequency is distal fractures are the maximum fractures because you know something called Colles fracture. Okay. The Colles fracture is the most common fracture here. So that is a part of the forearm. So forearm fractures, distal fractures account for 75%, middle third for 18%, and proximal is 7%, rare. Okay. So same thing, indirect injury during a fall on outstretched hand. Anything in the forearm, any fracture is due to fall on outstretched arm. Okay. That is the most common cause of injury in a forearm or a arm. Direct violence, maybe direct injury may be there, very rare. Road traffic accident may be there. Okay. So what are the clinical features? You know this all: pain, swelling, tenderness, restriction of motion. Okay. Any wound may be there if there is open injury, and distal vascular status and nerve status needs to be checked because any fracture may cause vascular or neurological injury. Anterior interosseous nerve and posterior interosseous nerve. These are the two nerves that are most commonly injured in a forearm fracture. So anterior interosseous nerve is only motor. Check thumb pinch. This is what you need to check. If the patient is not able to do this, that means the IN has been injured. And in a fully flexed elbow, pronation is restricted. And PIN injury may be there, posterior interosseous nerve, which supplies the supinators, the ECU, the EDC means extensor carpi ulnaris, extensor digitorum, and extensor, you know, I'll tell you what PIN injury, whenever there is a PIN injury, the patient will not be able to pronate or supinate. So radiographs need to be taken of the whole forearm. When only one bone of the forearm is broken, integrity of proximal and the distal radio-ulnar joint needs to be assessed. So in children, if there is a distal radius fracture, it is known as a torus fracture. We'll see the X-ray. This is a torus fracture. You may say this is a green stick, but this is actually a torus fracture because of the twisting injury that has occurred. Now we come to green stick fracture. So the break extends through a portion of the bone, causing it to bend on the other side. It's like this. This is the bend. This is the fracture this is the fracture here, and the thing has been bent. So this is why it is known as a green stick fracture, because it bends like a stick, broken stick. So there may be, in green stick fractures, there may be single bone fractures causing, angulation of the fracture. It may be volar, dorsal, or toward or away from the interosseous space. In children, in green stick fractures, usually close reduction, because in green stick fractures there is no displacement, just a deformity. We correct the deformity and we give a cast. Immobilization in an above elbow cast, the elbow is flexed to 90 and you mold it according to the patient. So now, when are you going to go for an operative management? Compartment syndrome, if there may be compartment syndrome in the forearm. If there are open fractures, if there is nerve injury, vascular injury, or angulated close to skeletal maturity, if the patient is close to skeletal maturity around 16 years, 14, 15 years, and you're seeing there's a lot of displacement, then you go in for an operative management. So this is how we manage operatively in children. In children, we don't usually give plates, we give nails, and these are elastic nails because it is a growing bone. So that's why this is an elastic nail that we are giving, titanium elastic nail, and it along with the growth of the bone, it bends according to the patient. And you always have to remove it. Once the fracture has united, you remove the nail. So X-rays are taken at 1 to 2 week intervals, and if there is loss of alignment, remanipulation needs to be done. Adults, usually we give plates, like dynamic compression plates we're giving, like in the humerus we saw, same thing, forearm fractures, give a plate. So this is how we plate a forearm fracture. There was a mid-shaft fracture here, and this is a dynamic compression plate that has been applied. Complications of forearm fractures may be compartment syndrome, neurovascular injury, non-union, malunion infection, radioulnar synostosis. This means the radius and the radioulnar joints may be fused. So this causes restricted pronation, restricted supination. Infection may occur. Now we come to the main thing, that is the short note, Monteggia fracture. So there are two types of fractures here, special type of fractures which are coming as short notes in your exam, Galeazzi and Monteggia. Okay. So which one is which? How do you remember? Is there any mnemonic? So Monteggia is, what I used to do is, my friend was a Manchester United fan, so I used to remember like Manchester United. So Monteggia is upper ulna. So that is how I used to remember my mnemonic, and that Galeazzi will be radius. Okay. So Monteggia fracture is a dislocation, is a fracture of the upper ulna. MU, so M and upper ulna with the dislocation of the head of the radius. So the fracture of the upper ulna with the dislocation of the head of the radius, and the displacement is usually anterior. This is what a Monteggia fracture is. This is the proximal ulna. This is the radius head. It has been dislocated anteriorly. So this is a Monteggia fracture. Less than 5% of fractures are Monteggia. What is the name of the classification? You need to know Bedo classification for Monteggia fractures. Bedo classification. Type 1 is most common. We will see the pictures. So always see the radiocapitulum line. Okay, radiocapitulate line. The radium, this is the radius head, and this is the capitulum of the humerus. So you need to draw a line, it must be straight. If it is deviated, means there is a dislocation. See, this is deviated. Can you appreciate this? This is the proximal ulna fracture, and this radiocapitate line is going up. It is not going through the distal end of the humerus. So that means there is a dislocation here. So this is a Monteggia fracture. Excuse me. So Bedo classification, type 1 is anterior dislocation along with fracture of the upper ulna. Most common type. Type 2 is posterior dislocation of the radial head with the fracture of the proximal ulna. This is the X-ray. See, the radiocapitate line again is going out of the distal humerus. Okay, it's below. So it's posterior dislocation. Type 3 injury, there is lateral deviation. There is upper ulna fracture along with lateral deviation of the radial head. It's not anterior, not posterior, it's laterally. This is type 3. Okay, this is basically a pediatric X-ray. The bones have not fused yet. And type 4 injury, there is dislocation along with radius shaft fracture. So upper ulna has been fractured, radius shaft has been fractured, and there is dislocation. Again, the same thing, the radiocapitate line is out of the humerus. So this is type 4. So type 1 is anterior dislocation, type 2, this is type 1, sorry. Type 2 is posterior dislocation, type 3 lateral dislocation, and type 4 is dislocation along with fracture of the radius also. These are the 4 types of Monteggia fractures. So in children, what is the management? Children, close reduction, adults, open reduction, internal fixation with plates. Okay, and you have to reduce the radial head and you have to reconstruct the ligament there. It usually after the reduction of the ulna, the radial head will fall into place. If it's not falling into place, you need to open it and reduce it. So this is a type. Which type? Kun type. Type 1 fracture. Okay, and this has been fixed with a plate and the radius has reduced. Complications of Monteggia fracture may be radial nerve palsy, non-union, persistent dislocation of radial head. Radioulnar synostosis means the radioulnar joint, proximal radioulnar joint is fused, so pronation, supination will be restricted. Myositis ossificans is a very important complication here because there is new bone formation in the elbow joint causing elbow stiffness. So this is a Monteggia fracture in a child. Now Galeazzi fracture. So Galeazzi is radius, but it is a dislocation, is an injury pattern involving radial shaft fracture with an associated dislocation of the distal radioulnar joint. So Monteggia was upper ulna, Galeazzi is distal radius. The name, the spelling is important. Don't mistake the spelling, okay? Galeazzi. There is a double Z here. Okay. Accounts for 3 to 7% of all forearm fractures, more often in males. Distal third fracture of the radius, radial shortening, dislocation of the distal radioulnar joint. We'll see the X-rays. This is what it is. So this is the, wait, we'll see it in this one. Yeah, this is better. This is the radius shaft fracture. See, the ulna is dislocated. Can you see it? The ulna is dislocated from the distal radioulnar joint. So the radial shaft has been fractured and the ulna has been dislocated. This is a Galeazzi fracture. Okay. So management is again same. Open reduction, internal fixation, and the distal radioulnar joint must be reduced. And if you have to, that is not reduced, then you have to open it and reduce it and fix it with a K-wire at least. So this is a, see, the ulna is dislocated here. Distal radius is fractured, distal shaft of radius is fractured, ulna is dislocated, and you are fixing it, and here again the reduction is maintained.